See? He's right on it.
So you don't, you're so multitasking because multitask governments. Sorry.
No, it was a perfect segue. All right, so I'll start with introduction. My name is Regan Sarmento. I am a wife and mother of two. That's my husband back there. He was drafted into coming. And mother of two. I have a 17-year-old son who attends a local charter school, and I have my 14-year-old daughter who's a freshman here within the district. So I say that so that you understand that when I'm speaking to this stuff, I'm also a parent as well. I am not just somebody who's invested work-wise, professionally. I have spent the last 20 years working in mental health care, primarily in partial hospitalization environments. We'll get to that. If you don't know what a partial is, you will when we're done. But those 20 years have been spent working with adolescents and their families. And I find it rewarding, empowering for the families. No 2 days are ever the same, but they're good days, most days. But one thing that resonates, that happens quite frequently, is that when families start entering the behavioral health care realm, there are so many questions, and there's so much families don't know. So I wanted, when Sarah offered me the opportunity to come speak, I wanted to talk a little bit about behavioral health care, mental health, and how to access the various services. So saying that, to kind of bring you into it, the fidget sticks, thank you. I'm giving these to you guys, not just for any sort of swag or marketing, but because what we're talking about tonight is uncomfortable. It generally is uncomfortable. And it's not that it's all the stigma that surrounds it. It's part of behavioral health care when we're talking about it in relation to our family members, our children. It's tough to wrap our arms around, so it's got an air of sometimes fear for some family members as you move in this direction. So I wanted you guys all to have something to play with, to wrap around your fingers if you get really, really bored. If you want to, if he starts to nod off, wake him up. So that's what we're here for today. This is kind of nice. It's an intimate environment. I ask you, please, as we're going along, if there's something you need clarification on or a question, let's enjoy the intimate conversation and we'll build on it. Any questions thus far? Anything? She just pointed to you.
Yeah.
Oh.
Can you give me 2 fidget sticks, please?
Absolutely. One for each hand. Here. There you go.
Thank you.
But if you get in trouble, I'm not responsible. All right. So we're going to start. First thing, when we're talking about accessing care, the first thing we need to ask ourselves is there a problem with our kiddos? And I'm going to gear this more towards, we're talking about our kids, because this is a district. Typical versus atypical behavior. Oftentimes when I'm speaking with a family, that's one of the first questions. Is this normal? What's going on with my kid? So typical teenage behavior. Yeah, we're going to talk anywhere from 11, 12 years old up. They're a whole different beast now. And typical stuff that our teens do. There are periods of sadness where we're looking at them, they're laughing, they're playing Minecraft, they're doing any number of things. And then all of a sudden you look at them and it's like, everything just fell apart. It happens. That's a quick little moment of sadness. Worry or concern over social events. Homecoming just occurred, and I'm sure there were kids all over the place. What am I wearing? What do I do? What do I do if he doesn't ask me to dance? What do I do if I have to sit over there on the benches and the bleachers? That's typical still. Worry over their grades, their academics. That's, again, typical. This is normal with our kiddos. When it starts to red flag, it's when we start moving into major change in sleep and appetite. When I'm saying major change, I'm saying we're going from a kiddo who's maybe doing 7, 8 hours of sleep at night, and now they won't leave bed for an 11, 12-hour period. Or somebody who typically, the regular, maybe 2.5 meals a day, now they're eating a half a meal. Or excessively eating. Additionally, long periods of depression. When we're talking about the periods of sadness that come and go, we're talking about depression that it's going on for a day, another day, another day. And stuff that we used to do to get them moving and laughing, it's just not working. When we talk about the worry and concern, now we're talking about excessive anxiety. That the kids, instead of talking about the dance and what if he doesn't ask me to dance, now it's I'm not leaving my bed, I'm not leaving the house, I'm not doing any of it. This is terrifying. We know our kiddos can challenge our limits and our boundaries. That's what they're supposed to do developmentally. It's exactly what they should be doing. That's how they're morphing into adults. However, when they're getting to the point where it's not, Mom, what do you mean I can't go? It's, F you, I'm out of here. Try and find me later. Or the quick to anger or grumpiness. Again, they're teenagers, we're used to that. But when it's coming to the angers resulting in disruptive behavior, where instead when you say, I'm going to take your phone from you, rather than the typical grumble of a typical teenager, you end up with a hole in the wall. Definitely, that's atypical. A typical kiddo spending more time with their peers, absolutely. Again, developmentally appropriate. But now it's to the point that maybe they're off and they're with some peers who are influencing negatively. And you can't draw them back. Now we've moved into atypical land. Risk-taking with substances. Obviously, none of us want to think that our children are engaging in any use of substances, whether it be alcohol or vaping, any number of things. But the reality is, for some kids, there's going to be some risk-taking. They're going to try it out. When we move into a whole different direction, now they're engaging and they're utilizing substances for self-medication. That is now atypical. Also, the disruptive behavior such as self-injury, unsafe driving. I mean, again, anybody whose kiddo has a license, we all know the apps that we're watching, and we're seeing the speed limits, the speeds that they're driving. Well, if we see our kiddos out there doing 85, 90 miles per hour on the bypass, that's atypical. Questions thus far? Okay. So, finding help. Where do you find help? That's a big question. It's a huge question. I think the first thing is when we as parents are recognizing that our kiddo they're not following that parenting manual that we all got, right? That was a joke. Okay. We start scratching our heads and we want to know, how do I fix this? Where do I go? And it's back to that fear thing. It's a little scary because if I'm coming to you saying, oh, I forgot that, Sarah, sorry. I'm in a vulnerable position if I have to say, so my kiddo, saying some really weird stuff. You got any ideas? That's scary for a parent to reach out to a friend or anybody. How do I find help? So oftentimes a lot of parents are stuck in a spot where they're saying, let me think about that tomorrow. Maybe I'll reach out to a friend. Meanwhile, time's passing. And our kiddo who's struggling, they continue to struggle a little bit more. So when we're looking for help, it is difficult. And I'm doing that, I'm throwing that out there to kind of validate, because I think a lot of families throw their hands up and think, this is difficult. How do I do this? How does anybody find treatment, a therapist, anything for my kid, for their kid? It is difficult. And so I'm just kind of agreeing. But places where you can start looking, pediatrician office or family doctor. I know from many conversations with area doctors that they are finding a lot of kiddos are ending up on their doorstep these days, and it's not because they have strep throat, it's not because they have the flu, it's because they're struggling with some major feelings, and mom and dad and kid have no idea what to do with that. It's a tough spot for a pediatrician to be in. That doesn't mean they don't want to. I've talked to a variety of them who say, this is part of my job, it's part of my Hippocratic oath, but the reality is, what do I do now? They're sitting in my exam room, and I don't know where to go with this. But they're a good first place to start, because most pediatricians' offices are now doing screenings and asking all those questions that are really difficult for us as parents to ask. Another great place is school or educational placement, as evidenced by, you guys are sitting here. Our districts, I'm going to harken back, I've been doing this for 20 years. There has been a huge move with school districts, recognizing that the kids that they're educating, it's not just about education anymore, there's so much more going on. And a lot of school districts are bringing in specialists, various faculty, personnel, I'm using all kinds of different words because it looks different in every district, but they are there to help with the kids who are in crisis. Is it okay to speak to Downingtown? Fantastic district. Sarah Brooks has been with the district
For a long time.
Okay, we're just sticking with that, okay.
Over 10 years.
Is it really? Okay. Sarah and I'm just going to go, and Lori, and Regina Gaffney. This is more.
Give you names?
Go for it.
I mean, there are 10 prevention specialists now in the district.
Okay.
So we've expanded and doubled in size. So all of our two comprehensive high schools have 2 prevention specialists, Olivia Houston and Matt McFadden at Downtown West. Beth O'Rourke and Emily Jubeck is new to us at Downtown East. Jen Yost is covering the STEM Academy this year. It's a new position. And then Regina Gaffney, who you mentioned, has been with the district for quite some time, still at Pineville Middle School. Lori, sitting next to me, is at Downingtown Middle School. And then Michelle Cello is actually at Marsh Creek, new to us from Upper Darby. And then actually this year, for the first time, we have 2 prevention specialists specifically to our 10 elementary schools, both Rena Davis and Laura Sirico.
Awesome. You did that well.
Thanks.
Okay.
I'm good at that. I have.
So we have these people here. We have these fantastic people that is their job when our kid's in crisis. But it does fall on us as the family members, the parents, to reach out and make that first call, that first contact to say, I'm having a tough time here, my kid's having a tough time. Other places, if you're feeling that that's a difficult bridge to cross, insurance companies. Not going to be my favorite to go to, however, they do provide a listing that's expansive. We'll leave it at that, because I don't know who's watching. Of providers in the area. Additionally, reaching out to friends or family members, again, if you're comfortable with that. Clergy as well. If you are close to your church family, trust me, the area reverends, pastors, priests, they know who to point you to. Additionally, Psychology Today. If you're looking for anonymity, it is a fantastic reference, both online and in print, where very simply you can go ahead and put in what you're looking for and you'll get a list of providers in the area. So these are options. All right, what am I looking for? This is a big one. Oftentimes families are saying, all right, what is the difference? And there is a difference. I mean, typically out there, and there's a plethora of amazing providers, therapists and counselors. And I'm going to use that generically in that they could have multiple licensing credentials. They could be anything from LPC, licensed professional counselor, to licensed clinical social worker, LSW. There's all kinds of letters for this one. But they are all trained. Leads right into social worker. Also, they can provide mental health counseling as well. Therapist, counselor, social worker. I think the thing to take away from that is between the disciplines, everybody is highly educated, and when they're licensed, the licensure process, the education that's involved, the amount of hours that they are investing. This is not an easy license to come by. There's a lot of work that goes into it. So when you see a licensed provider, you know that they've done their work to get where they are. So just to kind of make you feel a little bit more comfortable. Psychiatrist. A lot of people often confuse psychiatrist and psychologist. The big deal is that a psychiatrist can diagnose and prescribe medication. Helpful to know. But that's different. There's a small handful in the area of psychiatrists who will provide counseling in addition to medication management. Very small number. But keep that in mind. If you're seeking out a psychiatrist, it's going to typically be a very quick meeting for medication management purposes. When you want to talk about the brunt of the stuff, that's an air quote, therapist, counselor, social worker, that's where you want to go. Additionally, psychologist, which is different than a psychiatrist in that they can diagnose various behavioral health diagnoses, but they cannot prescribe medication. Nurse practitioner, there seems to be a growing field that these are registered nurses. However, they've taken their education even further so that they can prescribe medication as well. And oftentimes will have a lot of the same privileges of a psychiatrist as well. When I say there's a growing number, it casts a larger net in the community. So that's what you're looking for.
But the costs also change depending on which provider you have.
Yes. Excellent point. When you're seeing a therapist, if insurance is covering it, and just to kind of speak to that, if insurance is covering it, then you're going to pay whatever copay is dictated by that insurance company. You can also choose to pay out of pocket for a therapist, a counselor. That's really a family's choice. When you're paying out of pocket, most times you can reimburse to your insurance and get some of that money back. Again, every insurance company is different. But to your point, a therapist counselor, if you're paying out of pocket, you can pay anywhere from $120 to $150 an hour. A psychiatrist, if they're an out-of-pocket provider, it's considerably more. So it's one of those things, a lot of families look to their insurance company as well to say, what is available to me? I strongly urge, if you find yourself in that situation, reach out to the people you feel comfortable with to get their feedback. Again, Sarah would be a wonderful, or any of the prevention specialists to say, hey, I'm at this point, I've got these people, is any which way you can kind of just show me a direction. Extremely helpful. Because while these are our kids and they are our biggest investment, and we want to make sure we're doing the best, we also want to make sure that we are providing the best care that we are able to as well. So crisis situation. I think the biggest thing with a crisis situation is how do we approach it? And making sure that we never minimize what's in front of us. That's the biggest piece. When we have a crisis, kind of going through these, a lot of us, and again, I'm going to speak as a parent. I have my own kiddos, and I do this for a living, and I think my husband will attest to the fact that there are times that my clinical hat doesn't walk in the door with me some nights. And as such, I'm still looking at my son thinking, you're 17, can we get moving? Can we do something? Why are you not focused? Why are you not invested? Because I'm still a mom. I don't always go right to, there's something more here. And by saying that, this is where I come back to, we can't minimize. When we see our kiddo, and we're talking about those atypical behaviors from before, we got to look it right in the eye. And by the way, I can always send copies of this PowerPoint to you if that is helpful. We got to look it right in the eye and treat it as what it is. So if our kiddo is not getting out of bed, if we are at the point where we are fighting every morning to get them to go to school, or they're spending inordinate amount of time in their room and just isolating, we've got to take it for what it is and not say, they're just kind of playing on their computer, they're on the gram and that's what they're doing, I'm going to let them go and do that thing. No, if this is now atypical behavior and we know our kids best, we've got to address it. Has there been a major loss, such as death within this kiddo's life, a breakup, or an exposure to violence? The breakup piece, I cannot underscore that enough. We've been down that road, I'm sure, where we've had those breakups. I, for one, can say, if I look back at some of that stuff, I'm like, oh, that hurt so bad. Even though 30 years passed, you still remember that pain that was. For these guys, that breakup it's major. It's major, and for some kiddos, it is tossing them right into grief and loss. That is significant as if they lost a family member. We can't minimize that. Exposure to violence. With the kiddos I've worked with, I have definitely seen a trend with what's happening in our world with kids being exposed to school violence. There's more hesitation, there's more anxiety that's building up among these young people that is terrifying them, that's keeping them at home, where they just can't go to school because they went to school yesterday, it was a bad day, they came home, it was on CNN that there was another school shooting, and it's terrifying, it's crossed the line. So hence, is it a crisis situation? Was there something that pushed them into atypical behavior?
When you're saying exposure to violence, you're not saying it doesn't always have to be an actual exposure to violence in their immediate
Correct.
setting. It could be what they're projecting or what they're taking in from what they're seeing
Yes.
in the news and outside of themselves.
Yes. It's a different world. I mean, sadly, it is a different world. And I can say, for one, I don't watch the news anymore. I may be hopelessly ignorant for a couple of days about what's going on, but I know I can't have a straight night of sleep if I've watched the news at 11 o'clock. And these guys are hit constantly with all the different feeds. If you're seeing withdrawal from family, friends, activities, if they're pulling back not just from you, but their best friend, and their best friend saying, I keep reaching out, I'm texting, and I'm not getting anything. Or maybe they were a star soccer player, and now they're just not. Now they're not going to practice, and they're sick every time it's game day. Something more is happening. If they're making direct or indirect statements of suicide, if they're saying, I'm going to kill myself, or I wish I could fall asleep and never wake up again, these are real statements. And as a parent, that's terrifying to hear. That's not something we ever imagined our kiddos saying, but the reality is, if they're saying it, I applaud them for saying it, and if they're saying it to you, I applaud even louder, because those are major statements that we can't ever turn around and say, oh, come on, you don't really mean that. Come on, just go to bed, you'll be fine in the morning. And when they say, I wish I could fall asleep and never wake up again, the reality is, that's passive suicidal ideation. They just haven't made a move towards an action. If they're creating suicide notes or plans, including posting on social media, I know we've seen this, we've heard this, we know it happens where they're putting out these dark messages. Honor it. If you're seeing it, if a friend tells you, hey, I just saw your son, he just posted this, I don't know what it means, it's freaking my kid out, but I need you to know. Hop on it, go into that bedroom, ask those questions. If they're making final arrangements, such as a funeral preparation, writing obituary, or giving away prized possessions, this is real. This is terrifying. Oftentimes when people look, hindsight is 20/20. After a family has lost a family member, and through the subsequent conversation, it's like, I should have known. He gave away his favorite teddy bear. He had that teddy bear since he was a year old, and he gave it to his big sister. I don't understand. That's why, because he's making some arrangements. Always err on the side of caution. Adolescents are impulsive. We know this. I mean, these guys, they make a decision and wham, they're there. I mean, that's why we adolescents are scary drivers, because there's a thought that passes through that brain, and they act on it. I often say to families, and as we're talking about constant supervision, when there's a kiddo who's struggling with suicidal thoughts, I let the family know it's the 2 o'clock in the morning when everybody else is asleep. That's the scary time. Because this kiddo, that idea hasn't lessened in their brain. They're just waiting for a time where they can go ahead and pull everything together. So, in addition to having a conversation, being honest with the kiddo, and it's a difficult conversation to have. I mean, it's probably the most difficult conversation you will ever have with your child, but have it immediately, not after dinner, not after a shower, not tomorrow, because if any of this is happening, time is absolutely crucial. Remove from the home all lethal means and provide constant supervision. When I say all lethal means, it's all lethal means. And that is a tough one to wrap your head around as a family member. That means you go out into the garage, you take the jump ropes out of the toy box. It means you're taking a look. If there's a bathrobe hanging on the back of the door, take the tie. If you have Tylenol, I know a lot of families are getting great and on top of locking up medication, bravo, absolutely. Tylenol is a lethal means. And I mean, as we know, we've seen the news stories. All of that, to walk through your house and take it all away. And to remove that doubt in your head that says, they're not really going to. Well, if we're at this point, it's that 2 o'clock in the morning. So I need a family to always remember, it's when your eyes shut. If they're in this awful crisis situation, don't shut your eyes. This is not the time. You'll catch sleep another time, but it won't be tonight. Where can you seek services? Valley Creek, you can certainly reach out to Valley Creek. They are a crisis situation. They can come to your home. You can go to them. They are open 24 hours. You can go to the local hospitals, ERs around here. You can call 911. Obviously, it's not the thing we want. We don't want to be that family that's calling 911 at 1 a.m. and all the neighbors are watching. But you know what? I would rather have an ambulance in front of my house making all the noise in the world than telling my family and my friends the next day, by the way, I'm making arrangements for a funeral. So I can't stress this slide enough. If they're out there, if this is what you're seeing, treat it as a crisis. Let them know you are there. You are there to help them get through this and start forward on the journey. And please, gosh almighty, don't minimize. Questions? All right, levels of care. Okay. So it's a crisis situation. What happens next? If we have that kiddo that we just talked about, we could look at inpatient psychiatric care. There, inpatient psychiatric care provides absolute immediate stabilization in a monitored setting. There are a variety of facilities in the area. We actually have a handful. Devereux, Friends Hospital, towards the city, Northeast Philly, Horsham, Brooklyn, Rockford.
Kids Peace Foundation.
Thank you. I'm missing the other one. Meadowwood.
Meadowwood.
Yeah.
Rockford.
Yep, Rockford. So we actually have a handful in the area that can bring a kiddo in. If you find yourself in an immediate situation, if you go to an ER and they're moving towards inpatient, they will actually work with you to get a bed and keep your kiddos safe while they look for that. It's a scary thought, though, and I think oftentimes a lot of family members are thinking in their head, one flew over the cuckoo's nest, and that's, gosh, that movie was probably 50 years ago. I don't want to, wow. That's not necessarily what it looks like, but it is a safe environment. So a lot of families, I caution them when we have to move in that direction, it is a locked facility, and that is because it needs to be for your kiddo's safety, so that we recognize that they can't run out, they can't hurt themselves. The goal is immediate stabilization in a safe setting. It's used generally for acute mental health needs, such as a suicide attempt. If there are urges where the kids say, nope, I can't be safe, Or if you as a parent are saying, I can't keep them safe, this is beyond my ability, then this is where you're at. It allows medication management immediately. None of us want to think about putting our kiddos on major meds, but unfortunately for some kiddos, that's what they need. If they were diabetic, we would not withhold insulin and say, let's work this out over time. We would be moving right in that direction. This is the same sort of thing. If we have a kiddo who's experiencing extreme acute levels of depression, then there may be a need for medication. And this allows the kiddo to be in a setting where there are doctors, nurses, orderlies to watch them. So if there is any sort of negative reaction, there's also going to be some way to help the kiddo get through that medication reaction. Typical length of stay is anywhere from 5 to 7 days. It can be longer, it can be shorter. I'm just going with typical. Most will offer family sessions prior to discharge. But I think the important thing here is this is for an acute need, just to stabilize. Stabilize is the underscored word. Whatever got to this point, it's not away, it's not fixed, it's not gone, it's still there. We've just gotten to a point where we're stable. Partial hospitalization is a step down, if you will, in that kiddos still go home at the end of the day. And what that means is they're immersed in a ton of therapy for about 6 hours. Most partial hospitalizations all follow the same model, and I'm going to kind of jump around, but it's 6 hours a day, typically for 8 to 10 treatment days. Some facilities take it a little longer. It generally should be for what the kid needs for increased continued stabilization. It can be used as a step down from inpatient treatment. But again, to the big part of this, these are kids who maybe they are still feeling some suicidal ideation, some thoughts. But the big difference is they're saying, they're still there. I still think that way. However, I'm not going to act on it. And you, mom and dad, you're there. There's conversation where you guys are conversing, and you know, and you're trusting them. So that's where partial hospitalization comes into play. It tends to be group setting, and there's a psychiatric component, so that if we started on a major medication and perhaps we need to increase the dose, or maybe we're going to change the medication, again, this is a setting where the kiddo is being seen daily, maybe not 24, obviously not 24 hours, but daily. It runs 5 days per week, no weekends. There might be a few out there that do Saturdays. I
I can think of.
think that's a thing of the past.
Yeah, not that I can think of.
There's an educational component. It looks different in different places, but generally, education is provided so that the kids are staying up to speed to some degree with their peers. And communication with the home district. Most programs will say, I've got your kiddo, and I'm going to reach out to Miss Brooks over at Downingtown, and we're going to talk about what's going on. Typical length of stay, as I said, is 8 to 10 days. That's partial hospitalization. Did you have a question, or just? Intensive outpatient, and this could also be a step down from partial hospitalization, or in some cases inpatient. And this is where it's very intense, but it's a step up from outpatient. It's still a lot of treatment. It's a group setting, 2 hours to 2.25 hours per day, 3 to 4 days per week. There is no psychiatric component. So that's a piece that plays a role here. For some kiddos, again, if we need that medication piece, IOP may not be exactly what's needed, or having to do IOP and then find psychiatric care in addition. But that's why you guys are here, because I'm kind of trying to fill you in on that.
Does this happen during the school day, after school?
After school,
After school.
yes. So typically these are kids, perhaps they were in an inpatient setting, they left, they returned back to East, and they're okay. They're doing all right. They're getting back into it, but man, there's still a lot going on. This would be after school hours, which is a lot. I know my son, if we were in this on this journey, his biggest argument would be with me, it's soccer season, what do you want me to do? No, all that other stuff. I would always say to a family, there's next year for soccer, but we've got to get this stuff because we want there to be a next year. We've got to wrap our arms around it. We've got to make sure we're doing what we need to do. So that's IOP. We love our acronyms in mental health. Outpatient care that's the typical outpatient, seeing a therapist once a week, maybe twice, but typically it's once. For 50-minute sessions, great therapists will be reaching out and trying to rope in the school district. If you want a list, let me know. But to try and provide some continuity, because school is their job, and for a lot of kids, this is where the stress is, so there should be some conversation. If you're looking for an outpatient therapist, I would highly suggest saying, what is your involvement with the school? And it's used for non-acute clients struggling with blossoming mental health needs or to continue stabilization. I say blossoming because maybe you kind of recognize there's something going on. I mean, we're not suicidal, they're still going to school, but things are slipping, they're a little off. That would be the time. Let's call it an outpatient therapist, and they're fantastic also working with the family. If there's a need for a higher level of care, they will help you move in that direction and what that looks like. All right, working with the school. Okay. How do I disclose? There are so many families that we feel, I'm going to talk as a parent, we feel like what's happening in our home is our own stuff, and maybe it should stay at home. The reality is, back to what I just said, this school is their job. If you and I struggled with something major medical happening, and we needed to be inpatient at Paoli Hospital for 6-7 days, chances are we're going to call our boss. We're probably going to call family members that it makes sense to call, and we're going to say, all right, I need help. But we're going to tell our boss, I got to tell you, it's really important for you to know that I had a heart attack. I'm just going to go with that. Because your boss is going to say, oh my God, you could have died. Yeah. And I need help from you before I get back to work. That's what you're going to say, and your boss is going to be on board with that. I hope so. If they're not, find a new job. But for the kids, it's the same thing. When they're in school, their boss is their teacher. It is their guidance counselor. It is the student body. And if you walked back into your job without ever having that conversation, it's not going to feel good, and you're going to be at risk. So are the kids. It is, I believe, almost necessary to, you can come on in, you're fine. Go ahead, have a seat. It's almost necessary to reach out to the school, to the guidance counselor, to the prevention specialist and say, I gotta let you know, my kid is struggling. This is what we're looking at. We've been seeing Jane Smith outpatient therapy. She's recommending a partial hospital. I'm terrified because he's got 3 AP courses and he's geared up for college, and I can't do this right now because if we do this, will he go to college? What are we going to do? Yeah, you need to rope in the school because you're going to find that the answers are so much simpler. Those AP courses, they're still there. There are so many ways that schools can work with families. It would blow your mind. And I think that's, again, 20 years working with the Downingtown Area School District, and this is, I may be biased, but I guarantee that this is absolutely real. They are by far one of the most accommodating school districts I've ever worked with. I've seen them do everything short of standing on their head to help a kid. And when we are obviously a district that is really focused on the academic rigor and making sure our kids are set up for success, clearly not me, but the reality is they will do whatever it takes when the mental health is in jeopardy. So I can't emphasize enough. Let the school know what's going on with treatment, what are their needs, what about the medication? I mean, some kiddos, when they're going through this process, they're put on some major medication, and to not notify the school or the nurse that there's some major side effects, seizures or extreme lethargy, any number of things, we're not doing the kiddo any service. So it's so important. Now that being said, this kind of leads into, oftentimes families hear these buzzwords if they have not moved through this journey before, or maybe there was never any need to have this discussion. They start saying, what do I need? Do I need special ed services? What do I need? This is very brief, very, very brief, but do I need an IEP or a 504 plan? In spite of mental health needs, no matter how great they are, the biggest question is education being adversely affected? If it's not, I mean, there could be a young person walking through the halls with untreated schizophrenia who's struggling with hallucinations. But you know what? If he's showing up in history, he's still doing well, and he's in math, and he's focused. Education's still there. Obviously, we want to pull together more to support this kiddo, but that's the biggest question. Is the education being adversely affected? A 504 plan, big words, modifies and accommodates, modifies. 504 just modifies the regular education in a general ed setting, which can be utilized when a student is not benefiting. I mean, you guys can read, but basically it's coming down to you are still responsible for history and biology and woodshop. But let's say you are struggling with anxiety and you're having panic attacks, and perhaps those panic attacks are being triggered by the noises in woodshop. Well, then we're going to modify that a little. We're not changing things, but we're going to change things up a little bit so your education is still achievable. Whereas an IEP is accommodating a specific barrier to learning that may or may not be within the general education setting. This is a very long evaluation period. If all the pieces come together that deem it's appropriate for special education services, and I'm not trying to bore you, it's just, this is one of those things that families say, well, what do I need? I like families to be walking into a situation with eyes wide open and understanding what they're asking for. But I think the most important thing is important to note, the presence of a disability does not automatically guarantee services. To be eligible, the disability must affect functioning at school. So again, back to a kiddo might be cycling through and they're on their journey with mental health and they continue to struggle, does not necessarily qualify for an IEP. I mean, we have to take a look at the whole picture. So I just caution families because I think a lot of families, when they get to this point, we're grasping, we're looking for any and all help, as we should. But at the same time, we want to make sure we're looking for the right accommodations for our kiddo. Hopefully this is going to be a journey that a kid is on for a short period of time. And then they're going to continue moving on and life is going to get a lot rosier. I don't want to see a family get bogged down, wrapped up in trying to get these services because the child might find that they're achieving health without the services. So just one of those things I throw out there. Questions? Okay. A little bit more about the 504 plans. And the only reason I say that is that this could be something to accommodate a mental health diagnosis currently. 504s, they may qualify if they have physical or mental impairments that limits their abilities to walk, breathe, eat, or sleep. So this could be a physical health compromise, it could be a mental health compromise, it could be ADHD. And the accommodations fall under stuff such as preferential seating, extended test time, reduced homework, visual technology aids, modified textbooks, adjusted schedule grading, verbal testing, nurses' visits. Again, these are not huge accommodations, and most families, I gotta be honest with you, in this district, if you present your kiddo to the school and say, we're struggling, they're gonna say, what do you need? What can I do to help you out? You may not necessarily need a document to put all this in order. This is just a good district doing what they can to meet the needs of their kids.
So 504 can be either short-term or longer-term.
Yes.
An IEP tends to be a longer period of time.
An IEP takes a long period of
Not
time.
just so much to set up, but that the child has that IEP usually extends over a number of years.
Usually, yes.
Okay.
Yeah. And a 504, again, it could be something for a broken leg or recovering from a broken hip. It's really for the now. And again, I watered all that down. There's Director of Pupil Services is pulling his hair out in special ed right now. All right, IEP. Again, more, if you guys want copies of this, I'd be more than happy. But to your point, when a kiddo is being identified with any of these on the right, learning disabilities, emotional disorders, you guys can read, this is stuff that they're obviously going to be working through with for a long time, which is why IEPs are designed to carry the kids, once they're identified, most often through their academic career. But the biggest thing is the goals. Back when I said accommodations, we're saying that in spite of the emotional need that this kiddo is suffering, maybe they're diagnosed with broadly emotional disorders, and because of 3 different diagnoses, major depressive, generalized anxiety disorder, PTSD. And we're saying because of that, they're diagnosed emotional disorder, and we're saying they still will receive their education within the least restrictive environment. However, we need to change some things. Maybe that means instead of being taught history in this particular class, we're going to modify the class and how it's delivered. That's an IEP. All right, so past the school stuff, what about us? This is the caregivers. These are you guys that are watching, who are here. Moms and dads, I can't stress enough. Back to that manual that we all got when they put that sweet darling in our arm. This was never in the plan. We didn't talk about this. When we talked about our kids growing up, we never sat there and said, I can't wait until we have to talk about a partial hospital. Can you? No, we're talking about the good stuff. We're talking about them achieving, them doing well. They're going to graduate. They're going to go off to Yale. We're going to do all that stuff. And things take a left turn. And behavioral health is now a part, and they're sitting at the table with us. It is so important. While we have that kiddo, he's ours, we love him, she's ours. Mom and dad, you are struggling as well because this wasn't part of the plan, and you're trying to do everything you can to make sure your kiddo is safe, they're happy, they're healthy, and at the same time, you're terrified because there's a lot that you may talk about, but I find a lot of families when they're here, I'll describe a family recently that their kiddo was being recommended to a psychiatric care facility, inpatient, and which needed to happen for safety. Dad, it was obvious, he loved his daughter to the moon and back, and he was resolute. I'm not going to do it. Nope, I'm not doing that. I've never slept apart from her ever in her life, and I'm not going to do it now. Mom's over there, and she's saying, you do this every time. Every time there's a problem, there's an argument. And what about her? And I'm watching the family dynamic, and it's obvious they love their child because they're both sitting there, and they're both hearing this information, and they love each other because I watch them continue to reach out and touch each other, and they're coming back. But at the same time, this episode it's a part of their marriage they didn't expect to have to be tested. It is so important for family members to also seek out support, whatever that looks like. There are various groups, I'm going to use that as a general term, within the area. There are, back to ministries, there are churches, there are religious organizations that provide support. There's NAMI, National Alliance for Mental Illness, that provides area support groups. But there's therapists that you can go to and see for marital counseling. Whatever you do, make sure that you're taking care of you as well. Because while the kid is going through this, they're doing a lot of work to change and get themselves stable, but they need to know that the whole family's moving towards health, whatever that looks like. Offering education and resources to caregivers, I mean, just like anything else, when we're looking for college for our kiddos, we are going anywhere. We're Googling, what can we do to make sure we're helping those kiddos move forward? Same sort of thing. Reach out, find whatever supports, resources you can for more education. The other piece of this, when your kiddo's struggling and they're on this journey, respect their boundaries, which is kind of tough, where I said earlier, go right in their room, knock down that door, ask those questions. But as the crisis is subsiding, respect their boundaries as well, because they're working towards health, and a lot of times kids will say, all right, yeah, I know this happened, and I know I tried to kill myself, but I'm better. Why is she sleeping in my room every night? Have that conversation. What do those boundaries look like? But at the same time, have the conversation. I'm terrified. I am terrified because it was just 3 weeks ago you were struggling. And respecting the confidentiality of the young person. This one, it's a tough one because I just said to you, reach out for support to those around you. But at the same time, respecting their confidentiality. It's not a great idea to call up grandmother, grandfather, aunts, uncles, usually right around the Thanksgiving time, and families are saying, I can't tell you, Martha was just impatient. I don't know what we're going to do about it. Thanksgiving. We're going to show, and she's got scars all over her arms. Let me tell you, Martha is not leaving her room. No matter what happens, she's going to be a hot mess. So respect her confidentiality. She needs to come out to the family and share her journeys when she's able, how she's able. And it's a tough one. It's definitely a tough conversation to have. But it's a thing I hear from a lot of kids. It's like, I appreciate, Mom is really trying to help me, and Dad, but why are they telling the neighbors? I just want to walk the dog, not have people look at me like I'm some sort of pariah. I get it. All right. They did give me a clicker thingy, but I'm having more fun walking back and forth.
Regan, do you want to speak just a little bit on that last piece around sort of like the age of confidentiality, especially for kids in their relationship with therapists? Because I think a lot of times we hear a level of frustration, understandably, from parents feeling like, I have gotten my child into therapy, I'm taking them on a weekly basis, or we're doing X, Y, and Z. And at a certain point in time, the child kind of has some rights.
Yeah.
And then it becomes kind of frustrating, I think, at times, depending upon the clinician. Sometimes I think parents feel like they would like more information than, unfortunately, the therapist is willing to share as they build a relationship with, especially like the teenager or the young adolescent. It gets tricky.
Oh, it gets super tricky. Putting on the clinician hat right now. So, in the state of Pennsylvania, kids 14 and over are even. What does that mean? That means if a kiddo comes in front of a clinician and they're 14 and over, a good clinician is going to say, I will respect your confidentiality unless anything you tell me is confidential, unless you tell me you're in imminent danger of harming yourself or someone else, or you're the victim of abuse. Everything else will be held confidential. So that means if a young person is revealing to their therapist that they were, I'm trying to think, it's tough, it's muddy.
It is, it's muddy.
It's very muddy. So rather than give very solid examples, a therapist needs to build rapport with that kid. There needs to be trust so that there is communication, solid communication. That therapist will hold very tightly to those two pieces where it comes to breaching confidentiality. That is out there so that kiddos who want treatment can access treatment, and the law is backing them up. That's why it exists. It is not to divide the family and the kiddo. That being said, that's for the kiddo who is seeking treatment and mom and dad, maybe just as an example, or there's a custody issue and dad saying, well, I'm not going to use my insurance for that kid, and mom saying, well, I'm not going to drive them, and that, unfortunately, it happens. But if that 14-year-old presents in front of a clinician, the clinician says, okay, they're here, I'm going to treat them because they're 14 and over, and they sign the papers to get in. However, it is so frustrating because as a parent, you want to know what is it that's triggering your kiddo. Why is it that we are here in this spot? And you want to pull your hair out because that's your kid, that's your baby, and you want to know why are they in pain. Unfortunately, that information cannot be shared without the kiddo's express permission. Sometimes there are kids who will say, they'll sign a release of information and they'll say, okay, mom can know I'm here. That's it. Well, you want mom to have any idea of how treatment's just progressing, if you're doing well or not. No, I don't want to, she can know I'm here because she drives me here. Okay. Again, a good clinician is going to counsel the kiddo to bring the family in because we want complete healing, and that's how we achieve that in most regards. But it's a tough one because we as family, I'm talking as a parent, we want to know the whys so we can help on the other side. But it is a tough one when it comes to confidentiality. It's very, very tough. And it's putting your trust into somebody you really don't know all that well to make sure they're keeping your kids safe and letting you know when they're not. That's a toughie. I'm going to do this. I'm going to hope that this comes through. Bear with. I find that video to be very, very powerful and stirring, just because it's the voices of the babies. So if you teared up, you're human, it's okay. I tried very hard not to do it because it's just very embarrassing with my makeup running as I'm standing up here. So the other piece, they give the number for the suicide helpline. If at any point you think you may need it, there is a text line for kiddos. As we know, our kids prefer to use their phone for just about everything. And talking is sometimes tough, but there is a text line. So if you ever want to pass that on or you know of anyone, it is 741-741. It is in my phone contacts. It's in there, so I can share it. I think I may have actually made my son put it in his phone, too. That's my son. Special little guy. And that's it. Any questions? That was, by the way, that was a ton of information that I threw in you in like 62 minutes. So, questions? Of course.
I noticed in the video that different, more specifically with females, you have the bird there, as like, if she's thinking about killing herself, or if there's stuff she can use to harm herself. Why did they say like she or herself, but really it could be anybody, not just a girl specifically?
It's a good point. I was not responsible for the production of that, but it is a good point because it can maybe lead one to think that one sex is more predominantly struggling. It doesn't matter. Unfortunately, the reality is mental health is the most indiscriminatory thing that we know. It doesn't care if you're old, young, black, white, pink, male, female, whatever your identification is, it does not care. So I guess that was actually a pretty good segue. It's almost like we arranged that. We did not, though. I can't underscore enough when a kiddo's struggling and says any of the things that we discussed tonight, hop on it, take it exactly for what they're saying because it's real. And we don't ever want to be that person who's second guessing. So again, err on the side of caution, throw up the red flag, whatever the case may be, reach out. I would rather reach out to the prevention specialist here and say, please check on my kiddo. She said the most awful thing last night. We were fighting, and she said, I just want to die, and I don't want to live ever again. You could pretty much guarantee I'm going to reach out first thing in the morning and say, pull her, do anything, because maybe she'll talk to you. And if there's more that I need to know, then tell me what to do. But I don't ever want to be the one that says, she'll pass, it'll be fine, it'll go. Questions?
I think the only thing that I might add.
Have at it.
Well, no, as you're kind of wrapping up, is just as a reminder for our parents that our kids are also kind of have learned and are learning this language, but are also, we're doing a lot of work around trying to not only increase awareness, but give our kids the tools that they need to recognize concerns in either themselves or their friends. And so I say that as Downingtown East will be the third high school tomorrow to do QPR training for their 9th graders. That was something that started last year and has continued this year. Many of our buildings have also done the rollout for Safe to Say, which is also a forum where kids can communicate their types of concerns in an anonymous fashion. And depending upon the degree of the concern, kind of dictates the response, either from the district or outside of the district, to be truthful. But so I share that just because I think, we're obviously trying to give information and resources to parents, and we're certainly doing that for our kids too.
Yes. I mean, yeah, exclamation point, absolutely. And the QPR is something that's happening all over the place. I think Chester County Suicide Prevention Task Force, they are doing trainings all over the place. So, yeah, our kids, there are times that a lot of families will say, we don't want to talk about it because we don't want to put the idea in their head. They're talking about it. They are. Are you talking about it? Is it a thing? Okay. But it's real. It's part of their conversation. It's part of their stuff. I would be lying if I said that there are times that I have seen things that were concerning on my son's Instagram feed that we've had to work through and address. They're there. So, did I keep you guys awake? Okay. That's it. If you have questions, I left my business card. That is not to drum on, oh, thank you. He's trying to get a free dinner, I'm sure.